Well, ladies and gentlemen, good morning. Can you all hear me okay? Small enough. Good. Welcome to the American Council for Technology Industry Advisory Council inaugural Federal Healthcare Working Group Forum. My name is Joel Horwitz, and I'm the Vice President for Federal Health for CNSI, and I'm the Industry Chair for the ACT-IAC Federal Healthcare Working Group. Now, last February, at the HIMSS conference in Orlando, I felt very fortunate to get a commitment for maybe 10 minutes of Dr. Cullen's time while we were there to meet for a brief sidebar conversation about the idea of creating a community of interest designed to support the federal government under the ACT-IAC umbrella. Well, sitting outside of the convention center on a bench in a very loud and very crowded bus terminal, what was slated to be a 10-minute, what I thought was just to be a very high-level, let's come to terms conversation, morphed into about a 40-minute strategy session that really has framed the conversation that we are going to be starting here today. My takeaway from that conversation, listening to Terry, was very simple. We can do better. Service members, veterans, and the American public deserve it. And for those of you who know Dr. Cullen, the loud bus noise was no match for her passion. And while I am no doctor, I can without reservation state that Dr. Cullen's passion is contagious. She has a passion for service and for her patients and for the health and well-being of the American public. And if you don't think I'm serious, just look around you today and see how much activation that contagion can cause. Look at the folks around you here today. We have the National Coordinator for Health IT, CIO for Military Health, the Program Manager for the Information Sharing Environment, the Technical Director for Health Data Sciences Institute at Oak Ridge National Labs, Co-Director of the Office of Interoperability for the VA, Assistant Chief of Staff for Clinical Informatics at the Richmond VA Medical Center, Counsel and Expertise on Healthcare and Privacy, Project Manager for the HHS Buyers Club, Director of the ONC's Office of Standards and Technology, the Director of Clinical Analytics and Reporting for VHA, the former CISO from HHS, and the Deputy Program Executive Officer for DoD Healthcare Management Systems. At the end of the day, it is my sincere hope that you too will catch that passion and that commitment to this topic as we evolve the goals of this ACT-IAC Federal Healthcare Working Group. As you know, ACT-IAC is a public-private partnership chartered and dedicated to collaborative engagement in support of the federal government's efforts to improve mission delivery to the American public. And today, each of us has been given the unique opportunity to expand that partnership as we engage in the first of what will be many conversations related to the business of healthcare. Today, we open the lens and expand our collective view beyond the traditional focus of what many frame as just health IT. And I think we misnomered that ourselves here, but it will not be that going forward. Today, we will focus on the core elements of the business of healthcare, including the pillars of business transformation and data standards and quality, and including the functional competencies related to, amongst other things, security and privacy, human capital, interoperability, and as well as the technologies and tools required to facilitate an overall improvement in population health. Today is that day. Together as a community of interest under the auspices of ACT-IAC, that we frame the agenda for ongoing opportunities to engage and support the federal healthcare community. As you know, this requires ongoing coordination and communication if we are to advance the goals of interoperability, meaningful use, continuum of care requirements, and key milestones for measuring improved population health. Everyone's participation is required. We invite you, we challenge you, and we expect you to actively participate in this important and critical conversation as we chart our path forward. Everything we discuss today will be collected and aggregated for the purposes of creating a prioritized, actionable agenda for this working group. There will be white papers, special projects, further conversations, and other programs with deliverables forthcoming from this working group effort. Your participation and leadership is required. So as you can see, this is not going to be a passive listening morning, so get ready to participate. This morning you'll hear an opening plenary from our esteemed federal leadership here. The plenary will frame and norm the topics related to federal activities, initiatives, challenges, and successes currently shaping and driving our overall federal health care strategy. This will be followed by 2 separate and concurrent breakout sessions, each with its own panel of experts who are making a real difference in the realm of our federal health care agenda. Each of you, as participants, will have the opportunity and the responsibility to engage in both panel workshops. After this plenary, each of you will participate in one workshop. Half of you will stay here for the business transformation conversation, and half of you will go to the other room that we have set up for the data standards and quality conversation. And after a 1-hour dialogue, interactive dialogue, I'll stress, you'll shift to the other workshop. And then at the end, we will all come back together for an out briefing of the day's conversations. Now, I just set the standard and the bar's pretty low. So John Teeter and myself are supposed to moderate these workshops. If we ask any of our prepared questions, it's your fault. You're doing something wrong. So please, be aggressive, be assertive, be prepared. This is collaborative. Engage, ask questions, share ideas, challenge yourselves and this group, and collaborate. First and foremost, a very special thank you to the Planning Committee. Terry Cullen for her sponsorship and access to be able to create this foundation that we together will further evolve today. John Teeter and Tony Tranquil for their significant efforts in helping to frame the agenda and to frame the topics and to bring everyone together to support this effort. We've generated a tremendous amount of interest, so many, many thanks to them. And a special thanks also, where's Reggie and Alyssa? They're there. Reggie and Alyssa. Reggie Humphreys, Alyssa Smith, thank you very much for all of your hard work as well. And to the ACT-IAC staff, principally in the back there, Rachel Lynch and Robert Smith for their help in coordinating this program. And I'd also like to thank our sponsor for today's event, Varonis. Please turn your cell phones off if you already haven't, or to silent mode. And at this point, we will engage in the conversation. And for the sake of expediency, since I've wasted enough of your time, I will leave their self-introductions to the panel as we go forward.
So you're saying I can be anybody I want?
Sure. All good.
So I think I'm to go first. Is that correct, Terry? Terry's in charge.
No, I'm not in charge.
Well, good morning, everybody. I'm Karen DeSalvo. I'm the National Coordinator for Health Information Technology, and I think what we're going to do is each make a few remarks, and then we really hope that we'll have a chance for some dialogue with all of you. ONC, the Office of the National Coordinator, has just celebrated 10 years of serving the country, and when established in the Bush administration through work of the Office of Management and Budget, the notion was that there needed to be coordination across the federal government around health IT policy and technology, such that we were, first of all, as efficient and effective as possible as a set of agencies and departments, but also so that we sent clear signals to the private sector as we worked with them to engage and go forward and realize this promise of digitizing the health care and health experience in America. And if you think about where the world was 10 years ago compared to today, I think the priorities then, of course, included some of the same priorities that we still want to carry forward, which I believe we'll speak about some. For example, connecting care through the movement of data across the care continuum and beyond. But we did not have data actually to share in the way that we do today. So just as a reminder, about 5 years ago when the Office of the National Coordinator was put into law in the HITECH Act, it gave us a set of responsibilities in partnership with others like CMS to push out funds to the country to catalyze the adoption of health information technology, particularly electronic health records at the point of care, to show that we could improve the care experience of every American and bring health information to bear that would improve the quality and safety and effectiveness of care and reduce cost, leading towards that three-part aim. Dramatically successful progress in the Meaningful Use program through the adoption of health IT on the front lines in the private sector for meaningful use providers. I think you all probably know the statistics, but it's more than 90% of eligible hospitals and about 3/4 of eligible professionals. And in this country, essentially every discharge from a hospital, there's a digital record of what happened for that patient's care experience. It's about 97% of discharges. That success and the work of the grant programs to move culture and bring people together to begin to test new ideas around interoperability or community-level population health work to advance the workforce capacity, and to see that we were thinking through better ways to create the infrastructure on the ground in states, the laws, the expectations around moving data, brought us to a place today where I think the hue and cry is loud for that data to not sit in silos, but to be freed, as some say, so that it can be put to the use, so we can begin to see the return on investment, to see the value proposition for that data, not just in that clinical experience if it's there for continuity, but really as people in this country move across healthcare systems, move across state lines, change insurers, change doctors, that data, that information needs to follow them. And we also know that there are so many increasingly powerful uses, not just around payment reform, so better value understanding of the care experience, but all the way to public health, and then back again into what used to be a dream, more of a learning health system, and is becoming a reality today with frontier work in precision medicine, where we can take your genomics and healthcare data and personal experience of your lives, your behavioral choices, your family history, some of your environmental exposures, and mass customize your care and advanced science in such a way that it's, as a physician, if I think back 20 years when I was in school, it's unimaginable to me about how much we can treat a tumor cell in a way that we really were being much more blunt in the past. So that promise is really exciting, but I think for us at ONC, what we see is there's not, that there has been 1,000 flowers blooming in many ways that has really helped advance that work. And as I go around and talk to state governments, talk to clinicians on the front line, speak to other key stakeholders in the environment, there is a need for us to have a more structured approach, again, to not just adoption, but also to interoperability and then to the uses. So just how we have been undertaking that the last few months, and then what we're looking to ahead is how I'm going to close, because this kind of goes back to where ONC started. And you know, in my few months in federal government and my learnings from smart people who have been here and from my predecessors who are also smart people, I've really gained a tremendous respect for how important it is for the country to have the federal government as a major purchaser of care, payer for care, provider of care, and purchaser and user of health IT systems to be aligned and to really have a clear sense of where we are with respect to, for example, technology, how we're going to deem or certify that products are what they say they are, how we will handle privacy and security, what is the way that we can sustain the flow of information, not so much within the federal government, but when, for example, a soldier or a veteran needs to change and get care in the private sector and the data needs to follow them. How do we interact with the private sector? And then how are we going to govern all that long term? How are we going to make certain that we all have a set of shared rules of the road that we can agree on? We have been working with 35 departments and agencies across the federal government to reset the federal strategic plan, which isn't just a strategic planning exercise. It's about priority setting. It's about stopping for a moment to realize that as was alluded to, health IT is vast. It's a vast ecosystem. It's certainly more than electronic health records. That if we want to advance continuously in this country, we have to look beyond the kinds of programs that have been right in front of us the last few years. I mean meaningful use, to think about all the levers that we as a federal government have that we can pull in concert to give some clear expectations to the private sector, but also to advance for our own populations and in partnership with the private sector. And think about how we can advance health even beyond the healthcare system. How do we create a health IT ecosystem that's inclusive of data trading partners that touch the lives of the people in this country that are in it that's more than healthcare. So the simple ones are human and social services that you might consider, but certainly those beyond the meaningful use program, like long-term post-acute care, behavioral health, or dialysis. The execution on the plan is where things get really important, right? So we can write pretty things on paper, and we'll put that out for public comment sometime in the winter, and really want your feedback about whether you think we've decided the priorities for how to spend the federal dollar make sense, and if those are the kinds of approaches that we should take. But we don't want it to be just a piece of paper on a shelf. We want to actually move forward. And so coming to consensus as federal partners and seeing that we implement and have the opportunity to move strategically in concert with the private sector requires ongoing conversation and structure. And what we have been looking to on the federal side is how we can leverage what is the federal health architecture, a storied and well-established organization inside of the federal government that did a lot of good work, and I think in some ways got a bit overshadowed in everyone's minds by the high tech and the billions associated with that. But there's so much power and opportunity for us sitting around a table, which we just did last week with the VA, the DOD, and the SSA, and the Post Office has joined us now, and the Indian Health Service, and I can explain why the Post Office if y'all are interested. But what I'm saying is this is a broad set of federal partners who have been working together, so have relationships, but have realized that it's time for us to become more strategic around that table and think about a way that we set priorities together, a way that we work to be more efficient and effective as a federal government, to set clear expectations from technology all the way through governance of the data, and execute on that as a partnership. So I expect that you'll be seeing and hearing a lot more from us about how we want to structure our conversations in the federal government, and really all to the end of this is, I feel strongly that this is an obligation that we have to the American people, that we are working as seamlessly as possible so that it's not confusing when you try to interact with us, and that we have really a shared approach to something as important as the digital content of what is a fifth of the economy. Thank you all.
Thank you. Okay, great. Good morning, everybody. Dave Bowen. Karen gave me some great lead-in topics around spending, federal government spending in the health sector. I am the Director of Health IT for the Defense Health Agency, a newly formed agency within the health area of the Defense Department, and I'm the CIO for the military health system as an advisor to Dr. Woodson, our Secretary of, or Undersecretary of Defense for Health. The DoD, I'm going to probably give you more of a DoD perspective. I'm not a clinical informaticist. I'm sort of a classical health IT guy, so I'm going to talk about sort of what we're doing in the DoD to address some of these issues, and particularly where we see the role of data playing, and where we see issues, and what we see sort of as critical success factors when you really try to use data to run a health system and start dealing with the tactical problems of collecting and analyzing data. By way of background, DoD right now, I guess our budget this year for healthcare in the DoD was $53 billion. It is 10%, right at 10% of the total Defense Department budget. That's projected to double by 2030. So in the next 15 years, healthcare costs are significantly expected to impact the DoD. Obviously, that's not a tenable situation. And in 2010, Congress took some steps to begin addressing healthcare costs in the Defense Department. Basically, what Congress asked the Defense Department to do was to stand up an agency that would bring together the health services of the U.S. military together into basically a single organization, and look at how do we combine our healthcare resources across the 3-4 services into a relatively single and cohesive organization to hopefully take advantage of our scale and deliver healthcare a lot better and a lot less expensively. The other thing Congress asked the DoD to do was to, in that organization, look at how we provide services to our healthcare providers and to our consumers of healthcare within the DoD, and look at what kind of services could be consolidated to be more efficient and more cost effective. We formed a committee, looked at a number of different services, and basically started off with 5 services that we felt could be consolidated into a shared service model to serve all of the services within the DoD. And the 5 services were facilities, logistics, pharmacy, healthcare operations, and finally IT. And so we had to do a business case and go through a sort of a modeling exercise that sort of looked at what our potential was to save money within health IT. How could we organize more efficiently? How could we produce an IT product, deliver an IT product more effectively, and tell Congress what kind of money that could save? So we did that, and we stood up the Defense Health Agency last October 1st, 2013, and so we're coming up on our 1-year anniversary. So we've been in the process of trying to put all of the IT organizations together and consolidate our infrastructure, our data, look at how our facilities report their performance, and how do we basically move forward collectively to save money. So with that in mind, I thought I'd talk a little bit about some critical success factors that we're seeing specifically around data and around the infrastructure that supports our data initiatives. We're trying to figure out now, as a military health system, and I use system now in the truest sense of the word, like a Kaiser system or an Adventist system, like a lot of these commercial and private healthcare providers have come together and joined forces to form a system. We're trying to do the same thing, certainly within the DoD. We have a lot of people, both patients now, that cross service lines. They may be a Navy, person in the Navy that gets seen by an Air Force dock or whatever. So more and more that we're seeing a blurring of sort of the inter-service lines and sort of more of a unity of taking more of an approach around a unity of service provision. So with that in mind, a couple of things I would like to talk about, and if you have any thoughts, certainly you can ask a question. We can have a dialogue as we go forward. The first thing in my mind is standardization, and when we look at how we're going to use our data and how we're going to collect and disseminate our data, standardization becomes a very critical success factor. I was never in the military. My background has basically been health IT almost my entire career. And when I came to the DoD, I was amazed that the services do almost nothing the same. They do almost everything differently. Their HR procedures are different. Their finance procedures are different. My clinicians tell me their care procedures are different. And so trying to bring all of this stuff together, particularly given the culture of the services, is really a challenge. But certainly if we're going to be effective in doing some of the things that Karen talked about, fundamentally we've got to define how our data, we've got to define what our data is going to be, how it's going to be collected, and so to be successful, we've got to be able to compare the data, and we've got to make sure that the data is in fact comparable. So standards are a huge component of this. What I tell my folks as recently as the other day is that we've got to analyze what we've got. We've got to standardize the stuff that's non-standard once we decide the standards are, and then we've got to rationalize all the non-standard data and activities into some sort of a standard model. So we have a base of data that's basically comparative. Another factor for us that we're finding is around governance. Certainly data governance is an area we're just getting into. We're asking our Surgeons General to approve a data governance capability within my organization that will oversee the collection, the dissemination, the designation of data in terms of what is my system of record for a piece of data, where does it go, what systems need it, does it need to be exported, does it need to be imported, how is all of that managed, and how is that managed in a cohesive fashion. So again, we understand what our data looks like, we understand where we're sending it, and frankly right now we're not sure all the places where we are sending it within the DoD, but we're trying to get our hands around that. What's coming in, what's going out. We actually have done some analysis that shows our systems are sending data, some systems are sending data to other systems, which in turn go through some imaginations and send the same data back to the first system. So clearly we've got kind of a spaghetti pile of data transmission that we've got to work through. I think there's going to be a lot of talk today about infrastructure that supports data analysis. Again, we're trying to standardize our entire IT infrastructure across the military health system, what we call D2D, data center to desktop. That is something that's not been done in the past. All of our what we call our MTFs, our military treatment facilities, our 400 and so hospitals and clinics have been pretty much doing their own thing in terms of infrastructure, and so now we've got to get our arms around that and sort of provide a standardized platform that's much more manageable and capable of supporting not only our operating transaction kind of data, but an infrastructure that's also capable of supporting all of the analytical work, the data analysis, et cetera, that we're going to be talking about today. So certainly use of standard tools, techniques, and procedures. Again, 3 different services, they're all using different tools, they're all doing different things, they're all using different techniques, and we've got to try to get our arms around that. The other thing about infrastructure, I think, is that's important, and as many of you know, the DoD is embarking on essentially a standardization effort, but basically an effort to acquire a new electronic health record for deployment across all of our facilities. We believe that that's going to be very beneficial for the provision of care for our patients, but we also believe it's going to be very beneficial in helping us to more effectively manage our healthcare delivery system, as well as the interaction with our external providers. But that takes care of a lot of the clinical stuff. We also have the same effort on the financial side, and if you're really going to do a comprehensive analysis, you're going to need to have both the clinical data and the financial data available, again, in a consistent manner to enable effective analysis. And so we've got to have data architectures that enable us to consolidate and combine that clinical and financial data. So those are kind of some of the main areas we're working on. The other fourth one I'll mention briefly, and we can talk about it later, and that is privacy. And that is an area of data ownership, trying to figure out who owns the data and who does the data belong to. I can tell you that in the Department of Defense, the department takes the position that the Defense Department owns the patient data, that our military service members serve in the military. They are part of the Department of Defense, and their healthcare data basically belongs to the department. Now that's okay, but when you start thinking about where am I going to send that data and who is going to see it, you run afoul of DoD regulations in terms of, okay, DoD data is now going outside of DoD systems. DoD, for those of you who don't know, and if you're not knowledgeable about this topic, consider yourself lucky, but DoD has a very extensive information assurance, i.e. cybersecurity, set of regulations that govern how we operate and certify and secure our systems. And the position of the DoD is that any DoD data going to an external system that external system needs to operate at the same level of information assurance that the Department of Defense systems operate on, and that is a problem. So this whole area of data ownership, where I can't send DoD data to an outside system that's not certified, and yet my DoD member can get his data, and he can send it once he gets it privately. He can send it, he can fax it, he can do whatever he wants to the same provider. So we're kind of wrestling through all of those issues. So again, those are some of the critical success factors that we're dealing with. We don't have all the answers. Maybe I'll get some answers out of the crowd here, but that's sort of what our health IT situation within the Defense Department is right now.
So good morning. I'm Sharmendra Paul, Program Manager for the Information Sharing Environment. My office is administratively housed in the Office of the Director of National Intelligence, but we're aligned with the White House. I co-chair the White House's Information Sharing and Access Policy Committee. Now, we have a dual mission. One aspect is terrorism-related information sharing whole of government. That's not why I'm here today. Right? So the other aspect of our mission is information interoperability, information sharing best practices. That's why I'm here. There's in my core problem area of terrorism-related information sharing, there's a lot of similarities structurally, a lot of opportunities, I believe, to leverage lessons learned and best practices into both directions with the healthcare IT, public safety, human services domain. I can say that. I can also say that the problem that you all are facing in the health IT, human services area is much more complicated than the problem that I have in terrorism-related information sharing. So sorry about that, but that's and I say that in part because I've been around the space. In my previous job, I was the federal chief architect at OMB. Karen mentioned the federal health architecture. Quite a wonderful piece of work. Back in the day, I remember sitting through reviews and amazed at 40 cents on every dollar back then, and I'm sure it's a bigger number now, was federal or state or local public sector money going into the healthcare system. So clearly there's an opportunity there. Another kind of structural aspect that's very similar is the degree of fragmentation, right? And Karen also talked about this, and Dave. We as public servants have an obligation every day to work to reduce fragmentation, overlap, duplication, improve delivery of services to citizens, and simplify, right? Now, whether it's the health system or the public safety system, none of these were designed as an enterprise to begin with. They all emerged organically. That's not a problem. That's a feature. That's how it works in our open society and our federated democracy. But today the problems, the challenges we face are cross-boundary. An example, and something I'll get to in a minute, is even just looking at the nexus between public safety and public health. Mental health issues, prisoner reentry, prescription drug diversion, heroin is an issue. These are all big cross-boundary issues, right, that are national in scope and require effective sharing of best practices, effective interoperability at the policy level, the mission business process level, and so forth. Now, the administration recognizes this. President Obama signed out the National Strategy for Information Sharing and Safeguarding back in December 2012. That strategy takes the frameworks we've championed, the distillation of best practices and lessons learned over a decade plus of terrorism-related information sharing, and extends it across the entire public safety, public health domain. Three key principles. Number one, information is a national asset. So as an asset, you have to safeguard that information from a security perspective, as Dave was talking about. The privacy of our citizens is represented in that information. It's a valuable asset, and the asset's only keeps its value if safeguarded. But you generate value through sharing the information, right, across a life cycle in a policy-compliant way. It's a big idea. Principle number two. Sharing and safeguarding has to happen at the same time. All too often, we do safeguarding over here, sharing over here, right? Risk of information compromise, risk of mission fulfillment. You really can't treat those as two separate problems. You have to bring them together. The third principle, why do we share information? To make better decisions, to protect the American people, and in my case, enhance national security. Right? So the key idea here is a simple one for an engineer like me. Let's develop policy and requirements based on the decision requirements. Right? What do we want to accomplish, and let's work backwards to information policy. Now, that's not the way the world has worked. For quite a number of decades, we do policy based on classes of information and then worry about how do we get around that policy, or how do we get around that policy. I didn't say that right. Take that back. How do we work within the policy and address the issues, right? And so please, it's early. I only had one cup of coffee. Don't quote me on that.
Are there any press here?
Yeah. That's right. I'm already getting myself into trouble. And not even halfway through my opening remarks. That strategy, those principles, I hope you all see the overlap, right? See yourselves in that. Now, I do believe there's opportunities for cross-fertilization, and let me get very specific in two areas. By law and policy strategy, we've been working mainly with our state and local partners. Now, we work whole of government, the intelligence community, defense community, state, homeland security, and so forth, but a big focus with our state and local partners. I talked about fragmentation. In this country, 18,000 police departments, 90% of which have 50 or fewer sworn officers. Right? You have to use standards, common approaches. You have to be worried about training, effective protections for privacy, civil rights, civil liberties, things like that. We've had a lot of success with things like the National Network of Fusion Centers to tie together our public safety enterprise. The Nationwide Suspicious Activity Reporting Initiative, Neighborhood Watch for the Nation, a standardized approach with built-in protections for privacy, civil rights, and civil liberties to be able to collect information and share it appropriately, things like that. As through this process, we've been working with the National Association of State CIOs. Now, there's a joke in that community that a state CIO doesn't start a Medicaid management information system refresh until 6 months before retirement. Right? Why? Because those are the biggest IT systems they're going to do, and they always go sideways. Right? Well, that community, right, wants to use interoperability frameworks, shared services, shared capabilities. There was an initiative that they started called START, actually, with CMS. An interesting initiative and one that's got some promise. But the key to making that work is information interoperability. There's an organization called Stewards of Change that's worked with CMS and several other folks, maybe many of the folks here in this room. And as ACT-IAC is bringing together a community of interest at the federal level, I think bringing in our state and local partners, in particular, as they want to leverage the advances that they have seen and are benefiting from in the public safety space and the public health human services space, I think there's a real opportunity here to cross-fertilize. There's patterns, not only at the information interoperability level, but also at the collaboration pathways, as Karen was talking about. How do you build a learning organization at scale? Things like that, to be able to cross-fertilize between the two different communities. An example I'll give you in this space is the prescription drug monitoring activity, which ONC has had a leadership role with, SAMHSA, ONDCP, and the public safety community, Department of Justice, Bureau of Justice Assistance, our state and local partners. It's actually a success. We've gotten a handle on prescription drug diversion, pill mills and things like that. The evidence of that is the street value of a black market prescription drug has gone up substantially. The problem is behind that, now you're seeing heroin is a big problem, public health, public safety problem. Right? Now, it's a real tragedy, but there is a little bit of good news in the sense that we've been able to leverage the public safety, homeland security apparatus that we've built as a nation, mainly owned by our state and local partners, to help do relatively real-time monitoring of heroin penetration. This has started in the Northeast. It's going across the country. Daily collection about heroin brands, penetration, victims. And this is a partnership with the public safety and the public health community. There's actually going to be a meeting in December in New Jersey where public health commissioners at the state level, superintendents of public safety at the state level are all coming together to leverage and to advance this work that has benefits in terms of allowing the public health community to target their interventions as well as on the enforcement side. Traditionally, two communities that always haven't worked together as well as they could and should are moving forward to deal with this priority threat and this issue. So that's kind of one area that I think there's some synergy as we're building communities here to tackle this. The other area is around our information interoperability frameworks. we've stood up something called the Standards Coordinating Council using a FACA exemption, Federal Advisory Committee Act exemption that my office has through our enabling legislation. So that includes ACT-IAC. ACT-IAC is a charter member, and I really appreciate the partnership. Jonathan Adelson is ACT-IAC's representative in our committee. I don't know if he's here today. As well as several international standards organizations, the Object Management Group, OASIS, the Open Geospatial Consortium, several industry groups. NIST, the Identity Ecosystem Steering Group, that's helping to implement the President's National Strategy for Trusted Identities in Cyberspace is a part of this group. So we've taken and distilled the information interoperability best practices and lessons learned over the last decade in the terrorism-related space into something called Project Interoperability, and we're anchoring that under the Standards Coordinating Council. The key idea is these horizontal frameworks, they need to be outside the four walls of government, anchored with our public-private collaborations. This has proven to be very effective, and we're kind of moving this along. And I'm happy to report that recently the folks that are leading the charge with MITA, the Medicaid Information Technology Architecture, have approached us and want to be able to align with Project Interoperability. Now, Project Interoperability includes tools like the National Information Exchange Model, which we're working to anchor underneath the Object Management Group, the Identity and Access Management kind of work under the NSTIC, Managed Data Attributes, tools to align reference architectures, just a whole bunch of different things that that are useful and give you a leg up as we're trying to do interoperability. So I think I just want to end on very positive note in that I'm really pleased to participate in this conversation, to come and do what we can to leverage lessons learned and best practices from the health IT community, the human services community, the public health community, to be able to share what we've done, right? Because that's our obligation as civil servants and leaders in the public sector, and we are very serious about that. Last thing I'll do, and I'll ask my colleague Ralph Corbett to stand up. Ralph, could you stand up? Ralph is my action officer as it relates to public health, human services. Yeah, we'll be both here for the morning, but I have to leave mid-morning, and Ralph is going to stay, and so if anybody wants to follow up with him. Thank you.
Thanks. There are some seats if you guys want to sit that are in the back. Not to point you out that you're all standing up. So I'm Terry. I'm the CMIO at the VHA. I'm going to start with a story. For those of you who know me, I usually start with a story because I was struck by, first off, the fact that we're not using PowerPoint. I know that there's a projector, so it really does say that sometimes low tech is appropriate, because what we want is a relationship with you. I would argue that's what health is about, a relationship we have with each other or with our healer or our provider. So I think this points out the need for us to try to ensure that health IT is in the background. And actually, I was asked this morning when I came in, so what is health IT? So I'm not going to take that one on, but I'm going to go back 31 years when I was an intern at Cook County Hospital in Chicago. For those of you who know, this is the old, I always say people, I trained at the old Cook County, not the new one. There's a great new hospital. An 1,800 bed facility, one of the largest hospitals in the country, a lot like Charity was in New Orleans. And when I was an intern, there was no computer. There was computer for some billing, I'm sure for some demographics, but I had no idea that there were computers anywhere. And I had a pager, where people talk, Dr. Cullen, please call 302. Anyway, the way we got our lab values was we had to call the lab. And we would call the lab and you were only allowed to get 3 values. So you could call and you could ask for 3 results. And so I was the intern, so you know how things roll downhill in medicine, and sometimes you had medical students and it would roll down to them. But if it didn't roll down to the medical student, it rolled to me. So I would be on the phone. You never slept when you were an intern anyway, but starting at 3 in the morning, and all you would do was hit redial, but there wasn't a redial, so you would actually call. So I think that the reason I bring that up is things are a whole lot better. And I'm struck by how much better they are, and that everyone in this room, everyone in this space deserves credit for that. But how much further we need to go. And actually that was one of the impetuses behind trying to set up really a relationship with industry, is that the federal government in and of itself is full of brilliant people. I agree with Karen. It's amazing the amount of expertise, knowledge, commitment, passion that exists in the federal space. But in and of ourselves, we're not going to be successful. We have to have a partnership with industry, and we have to have a partnership on these really large issues. And they were very well elucidated before me on the panel today. Some of them I'm just going to hit briefly on. Interoperability, huge issue, confronts all of us. Data is an asset. And I really appreciate you said how difficult it is in the health space, because in the health space it is so difficult. And there's days I think I cannot believe this is only how far we've gone, and then there's days when I sit back and say, oh my gosh, it's amazing we've gone this far. But data, interoperability, and in our realm, in the VA perspective, we're really moving, we want to get beyond interoperability, we want to get to operability. So it's that interoperability, I have your data, you have my data, but then I operate on it, I act on it, I know what to do with it. So it's not just the sharing of the data, it's the ability to use that data to improve care. And I really want to also talk about this whole concept of what do we mean by health, because I think all of us have alluded to, and Chandra, you just did that, Health and Human Services. And I was, before I went to the VA, I was at Health and Human Services, and I do remember, and John Teeter probably remembers this, when we were standing up a Health and Human Services IT investment domain, and we were doing health. That's all we were doing. We were doing health. We thought health was a big deal. And it was the secretary who said, well, what about human services, you guys? Like, health is really impacted that. And it was one of those, oh my God, moments. Like, right, the whole concept of how we improve health and how we achieve health and health equity in the country is really based on this ability to have these relationships, to know where the heroin is. I actually still moonlight in an emergency room. I actually know what's going on with heroin in the streets normally because I see what's going on in the ER. It's a non-VA ER, private ER where I moonlight. But having that kind of knowledge to help inform me becomes really important. So when we talk about interoperable data, we obviously have really focused on trying to do the standards related to health data itself. But we need to recall ourselves it's Health and Human Services. I would also argue this whole thing about MIDA and Medicaid and Medicare in the country is huge, and it affects Dave, it affects DOD, it affects me at VA. And how do we do data sharing appropriately with those groups? How do we make sure that that data comes in and is a true asset? How do we transition from the delivery of health, Karen talked about this, within the four walls of how we've traditionally done it, into this continuum of care, into this recognition that your most important caretaker may be your person that's at home, or it may be the person that's 3,000 miles away. And you should really ask Karen why the post office was at the federal health architecture, because it was also one of those ta-da moments. How many opportunities are we missing within the federal space because we haven't been provocative enough and challenged ourselves enough to think somebody else may really know how to do this, and how can I leverage that to get there? And so with that, I'm gonna stop. And Joel, do you want to facilitate questions, or do we even have time?
Anybody have any questions?
Post-op.
Yeah, actually do have a question. My name is Rob Clark. I'm here from the U.S. State Department. And in my particular organization, we provide cybersecurity training to anybody in the government space. And in many cases, that training is provided at no cost. I guess my question is kind of directed toward Mr. Bowen and Mr. Paul. What are your thoughts on how to get the word out with regard to providing that training, specifically with regard to HIPAA considerations and protecting PII?
Are you talking getting the word out across the federal sector, or the...
I can't put an ad in the Washington Post.
You have a response?
Yeah, I do. You can follow up with me. You could do a blog post on my blog. I'm sure that you can do the same with some of the other folks here. That we can get that word out. There's also some interesting communities of interest that I could plug you into. The folks in the White House, the Cyber Directorate, that can.
Ari Schwartz?
Yeah, well, yeah, that's right, Ari, and. There's also a lot of demand for cyber training in the federal, but also the state and local side. And so that's another angle here where we're working with our public safety partners. Yeah. They work mainly with the Secret Service and the FBI on this issue, but there is more demand than capacity. So if you've got capacity, I can connect you with them.
I might steer you to the Federal CIO Council and see if you can drive it from the top down. Certainly, we're interested in this from a standpoint of what we're doing in the medical community. We look to other parts of DoD to provide those services largely for us. But nonetheless, your point's well taken, and it is a very valuable service, and it sounds like you got a very valuable resource that we could take advantage of.
If I understand the organization you're a part of, the Department of State, I want diplomatic security. Okay. There's another aspect of the Department of State that does the training, core awareness training for the information sharing environment, but that's not. Yeah, that's FSI. Okay.
So the one thing, though, that does point out is what we know is that we all do our own security training. You know that, right? Like, we all do our own thing, because why? And David, I have to acknowledge how honest you've been. So I'm going to be honest. Does that really make sense? Are we all, like, we're all interpreting HIPAA differently? We all have our own HIPAA training. If I go through security training at the VA, just so you know this, if Indian Health Service wants to come in our system and see our data, we make them do our training because we're special. And I actually do think we are special, but I think Indian Health Service is special too. And so what we should do is figure that out as a federal space, and it's one of Karen's agenda items, I think, that we're moving forward.
Well, and coming from the private sector, when something like this comes up in my staff, the first question I ask is, okay, so who does this in the federal space, who does it well, and who does it in the commercial space? I operate it in an environment where if I've got an Army system that's information assurance certified, the Navy doesn't recognize that. We don't even recognize across services, certifications across our own services. So talk about stovepiping. We've got certainly some more work to do.
So let me do this. Thank you. You win a door prize, which we have.
First question.
Aging first. Federal policy, age first. And what we're going to do is we're going to take a 5-minute break. We're going to split up into workshops. The business transformation workshop will occur straight across the foyer area there. Get started. The data standards and quality will occur here. It doesn't matter how you split up. You'll ultimately get to vote. And those are going to be designed to be much more engaging, much more time for these types of questions, much more time for this sort of to give Karen her agenda.
We're very bored.
But Joe, before we break, we got to ask Karen the question, right?
Yeah. I hope you don't mind. You brought it up.
I'm already disconnecting.
There you go.
So the post office approached us because they have sort of a twofold agenda. One is that they have hundreds of thousands of employees for whom they are making a personal health record and a portal so they can access their health information. They also have a potential platform to create a way that every American has an identifier, like an address, a direct address, if you will. Because people have registered, and I won't remember the number, but Terry or Steve or somebody else who's here might recall the number, but it's in the millions of people who've gone online and registered with the post office to say they live at a certain address and they're a certain person. So it's not the level of authentication, for example, the DoD would expect, but it does create an interesting
identity.
That's correct. It starts to create an identity opportunity that opens your mind to the potential of, for example, data being centered around a person, in a more person-centered architecture, something that folks talked about in the past and are talking about again, that gets us to an ecosystem that is not so dependent on the healthcare institutions hosting the data. There might be opportunity for other trusted third parties, but for individuals to have some identity management.
So the one thing I would say, Bill, is that I think that it was one of those aha moments for me. I happened to be in that meeting, and I went, whoa, we have so many resources throughout the federal space that we never think of. I actually don't really think of the post office as identity, but why wouldn't I think of that? I get mail and it's addressed to me, and it comes and they know who's in my house, and they know how to forward things. So I just think that we have this really unique opportunity as we look forward and we embrace the amazing work that other non-traditional health partners have done in the federal sector, that we can accelerate movement to where we want to go.
I think on that note, it also expands thinking potentially to include less about the systems for the sake of the systems that we're creating, but more about the individual as the center of all of that. And those types of unique identifiers or other options or resources are the conversation.
You know, if I might, this raises, I think, the issue for all of us that has been said, and I'll just underscore it, is that sometimes I think we've been working to define or consider solutions in the health IT space, thinking about health care. But the truth is that there are assets and strategies that have worked in other arenas, whether it's public safety, that we should look to, leverage if it makes sense, and get ourselves out of that traditional thinking of the House of Medicine.
Thank you all very much for this.